Welcome to OncoPharm. I'm your host, John Bazar. I'm a professor of pharmacy practice at ETSU's Bill Gatton College of Pharmacy, and this podcast is sponsored by Kelly C. PharmD, an oncology education company for pharmacists. Today we are launching the first in a series that we will do periodically. This is a targets series where we talk about drug targets. And today we're talking about Trop2. And these, if you go to the YouTube channel for OncoPharm Pod, which is not thriving, I would say, because there's not a whole lot on there except audio podcasts. But we do have some slides to go along with that. And these slides were put together by Zach Kennedy, who was graduating very soon from our College of Pharmacy here, and he's going on to residency, going to do great things. But he was on my Biomedical Communications APPE. And so this is some stuff he put together on Trop2, which we're going to get into. So Trop2 is a transmembrane protein that is localized to the cell surface with efficient internalization. It leads to MAP kinase pathway activation, heavily involved in intracellular calcium signaling and translocation of oncogenes. Physiologically, Trop2's role is a little bit challenging to suss out. It's not like epidermal growth factor receptor where it's on epidermal cells and it's a little bit obvious why it's there to help maintain that cell and that tissue type. But it regulates epithelial promotion or proliferation and survival. It's crucial for embryonic development and especially in the placental trophoblast is where Trop2 comes from. It maintains stem cell self-renewal capacity, and I mentioned about its role in calcium homeostasis. Now, why this is important is Trop2 is overexpressed in more than 80% of solid tumors, and this is associated with poor survival and aggressive behavior. And Trop2 is involved in the epithelial to mesenchymal transition. That is part of the process that allows, say, a breast cancer to invade distant tissue. Now, it's broadly expressed, Trop2, in many types of cancers, and it tends to portend an aggressive disease, and it is a therapeutic target, as we know with drugs like sacituzumab govitecan and datopotamab deruxtecan. So here's a nice large image looking at the Trop2 signaling, and you can see on our top left, our transmembrane Trop2 does not require necessarily a ligand. It's not like HER2 where it needs to dimerize or EGFR where it needs a ligand. It's sort of always active and easily activated in the way that most of these transmembrane proteins are. And this then activates on the left, number 2, the MAP kinase pathway. You can see a lot of familiar drug targets with RAF, MEK. You can see on the right the JAK-STAT pathway, another common drug target with JAK inhibitors, and then the PI3 kinase pathway in the middle, which includes PI3KCA that we target when it's mutated in breast cancer. So this leads to broad activation of cells to promote proliferation, division, and activation of these cells. Now, Trop2 is very heavily expressed in cancer. So you can see there that more than 95% of hormone-positive HER2 unamplified breast cancer has Trop2 expression, 92% with ovarian cancer, 90% with triple-negative breast cancer, more than 80% with bladder cancers. Then he goes down to 75% and 64% for non-small cell lung cancers, depending on if it's squamous versus adeno, 56% with gastric cancer, and that's pretty variable. It is somewhat normally expressed in the stratified basal cells of our skin, including the esophagus, cervix, tonsils. There's some glandular epithelial expression, but that's pretty low. That's not common. But it is upregulated transiently during wound healing, and then the expression goes back to baseline. We mentioned the heavy expression in the placental trophoblasts. So this tends to be something that gets put out there on the outside of the cell when the cell needs to divide and to grow. So I'm not sure if this is a driver of cancer growth or if this is a consequence of some other driver. In other words, this seems to be a gasoline. It's an accelerant to get these tumors to go. But what leads to the Trop2 overexpression, we don't yet, I think, know. But it certainly isn't a very attractive target because it is more overexpressed in the cancer cells than the healthy cells, and that is kind of a hallmark of a great target. And so there's a lot of great detail here about the gene expression, the transcription. As with most genes, there can be epigenetic tuning that happens. With these proteins, there like all proteins, we don't always talk about it, but there is post-translational modification that has to happen. And then the organization I won't get into because it's a little more in depth than what I want to get across from this. So why is Trop2 becoming overexpressed? We don't know. Perhaps it has to do with amplification of the TACSD2 gene. And so amplification in 1p32 is seen in some of these cancers. Epigenetic changes, is it transcriptional dysregulation? It has something to do with a microenvironment where something is happening, maybe from other cancer cells progressing that leads to this, insulin growth factor type 1 or TGF alpha stimulation that leads to this upregulation of Trop2. But what we know is that all these pathways, you end up with a whole bunch of Trop2 on the surface of cancer cells compared to healthy tissue. And that makes a really good target, especially if you have a very good linker and good payload delivery just to those Trop2 positive cells. And so we know that this has a role in proliferation and survival. There are tumor ecosystem effects with activation of VEGF and the JAK-STAT pathway, and then this mesenchymal epithelial to mesenchymal transition, which allows the degradation of these tight junctions, which allows them to move and to these cells to invade surrounding tissue. So we also know that Trop2 signaling can contribute to treatment failure and chemotherapy resistance, as well as endocrine resistance, and that some of these target therapies can bypass some of the resistance patterns to other treatment modalities. And there could be Trop2 resistance by downregulation of Trop2, efflux pumps that will pump out topoisomerase 2 as well, and then any myriad of other potential patterns of resistance. So we have our primary tumor remodeling, the breakdown of the tissue in that epithelial to mesenchymal transition, the attachment of the cells and invasion by degrading some of the integrin signaling, then dissemination into blood, which goes to other far areas and distant colonization. So I mentioned already, Trop2 is a nice target because it's overexpressed in a lot of solid tumors, but not expressed in a lot of healthy tissue. And there can be rapid internalization by antibody-drug conjugate binding to Trop2. And if we look on the right there, you can see that whereas HER2 is overexpressed in 15 and 20% of breast cancers, it's expressed on more like 85% of breast cancers and expressed in a lot of different solid tumors, whereas HER2 we think of a big driver of a subset of breast cancer and some gastric cancer, and then it's a little bit of colon cancer, a little bit of salivary gland tumors. It's lower. So it does look to be a pretty attractive drug target. And as we talk about the safety profile, we'll see that the toxicity of Trop2 targeting antibody-drug conjugates is dependent on both Trop2, but as well as the payload. So we have 2 on the market as of when I'm recording this, which is the end of April 2026. We have sacituzumab govitecan and datopotamab deruxtecan. And you can see there's really not a commonality to toxicity. Maybe you go to the bottom and say, oh, they all cause fatigue. Well, all drugs that treat cancer cause fatigue. These are drugs for advanced cancers. These patients are going to have fatigue. We can see that there's a lot more diarrhea with sacituzumab govitecan, but a lot less diarrhea with datopotamab deruxtecan. So that's probably not a Trop2 dependent effect. Probably has something to do with the payload there in the govitecan. And these are both, topoisomerase 1 payloads, but different rates of diarrhea based on what that payload is. We see neutropenia is more common with sacituzumab govitecan than with datopotamab deruxtecan. We do see that there's more risk of interstitial lung disease with datopotamab deruxtecan than to sacituzumab govitecan. We see ocular side effects with datopotamab deruxtecan, and you have to have the baseline eye exam. You don't see that with sacituzumab govitecan. You also see dose-limiting mucositis and stomatitis with datopotamab deruxtecan, where they have to actually use cryotherapy and suck on ice chips during the infusion in the label for datopotamab deruxtecan. They need corticosteroid mouthwash to help prevent that. You don't see that with sacituzumab govitecan. So that cannot just be Trop2, despite our knowledge that Trop2 is expressed on some epithelial cells and cells that are turning over and healing. So you can almost see how once you have mucositis, you might have more Trop2 expression on the healthy oral mucosal cells trying to repair, and why that mucositis could maybe be compounded with that. So this has to do probably with both our payload as well as our linker, and maybe one of the reasons you might see more neutropenia with one drug versus the other is linker instability. So key pathways, Trop2 is a regulator of stem cell self-renewal and tissue homeostasis. It doesn't have a defined role outside of embryonic development in everyday practice, but it is upregulated on cancer cells. It's not typically highly expressed on non-malignant cells. And so the cell needs to heal itself, needs to somehow make a copy. There's ischemia in the microenvironment, and now we need to make more cells in some way. Cells are harmed, need to make more cells, whatever. Trop2 overexpression tends to kick in, and that makes it for a very good therapeutic target. A lot of listeners to the podcast tune in because they're new to oncology, trying to keep up to speed, or they appreciate quick weekly updates to help keep pace with the onslaught of new information on oncology. Well, if that sounds like you, check out Oncology Insights Newsletter, a free weekly email written by fellow OncoPharm Kelly Karlstrom, founder of Kelly C. PharmD and the ELO Collaborative Program. Each week she shares practical pearls, ways to think through oncology concepts without just memorizing guidelines, and insights on staying motivated and growing in your practice. It's written by a pharmacist, for pharmacists, and it's easy to read. You can sign up in the link in the show notes below. And we have another one of these presentations done for her too, which we'll do in the coming weeks. There was a really nice article published recently about how a busy clinician should read clinical trials. I think we may do that because I certainly share a lot of the same sentiments with that, but I have some other things to add as well, specific to maybe to oncology pharmacists. So that is what I have for you this week. Thank you so much for listening. You can follow me on X at PharmDeepNib, and on other social media platforms. You can follow the podcast at OncoPharmPod. And until I talk to you again, remember, doses matter.